sickle cell disease, and talking about how that impacts neurodevelopment, discussing neurodevelopmental disorders and how they're common in these children and what those features are, and then reviewing the current guidelines for developmental surveillance, screening, and evaluation in children with sickle cell disease. So just to give you a little bit of background about sickle cell disease, I think most of you know this because it is one of the oldest genetic diseases that's ever been discovered. It's caused by a nucleotide substitution in the beta globin gene. One change in that one substitution leads to a change in the amino acid code, which creates the hallmark of sickle cell disease, hemoglobin S. And normal adult hemoglobin is 2 alpha and 2 beta chains. In sickle cell disease, those 2 beta chains are beta S chains. And in sickle cell trait, those patients have 1 beta chain and 1 beta S chain. And then in addition to that, there are several genotypes of sickle cell disease to be aware of. The most common form is SS, or homozygous type sickle cell disease, where both beta globin alleles have the S mutation. While it is the most common form, there are plenty of children with SS disease who do not have severe symptoms. And so a lot of people will say that this is the most severe subtype, but it's really depends on the patient and their clinical profile. Similarly, with SC disease, there is a mutation in the C for the C and the same beta globin gene as the S. And so those patients have 1 S and 1 C beta globin. And again, this is a less common form of sickle cell disease. And again, some would say milder, but it depends on the patient and their clinical presentation. There are also sickle cell disease types that are associated with thalassemia. Hemoglobin S beta null thalassemia is where they basically have no other functioning beta chains. And so it's predominantly hemoglobin S. And then in S beta plus, they do have functioning beta chains. And so again, it looks more like SC disease. And then there are even rarer subtypes, some of which I did not list here, but you can just see their names below. So sickle cell disease is a global disease. It affects millions of people worldwide. Predominantly in sub-Saharan Africa, India, the Middle East, Mediterranean area as well. However, in the United States, it's actually considered a rare disease, affecting about 100,000 Americans and primarily affecting people of color. You can see here these numbers are from the CDC, and they are estimates because we don't have a registry for people with sickle cell disease. But about 1 out of every 365 Black births in the United States are affected by sickle cell disease, and sickle cell trait is even more common, affecting 1 out of every 13 Black births. In addition, and again, I believe most of you know this, that sickle cell disease is a systemic disease affecting multiple areas of the body. And so these patients can have pain crises, or vaso-occlusive episodes that can be quite severe, requiring hospitalization. Acute chest syndrome or a sickling crisis in the lungs is one of the most common causes of mortality in sickle cell disease. They're also predisposed to certain infections because they auto-infarct their spleens at young ages. And so encapsulated organisms, they can be at risk for infections from encapsulated organisms. But of course, the complication that we'll mostly be focusing on today is stroke. So there are different types of brain injury in sickle cell disease. At the top of the list is overt stroke. Sorry, let me turn that off. At the top of the list is overt stroke, and that is the stroke that we see commonly in adults in neurology, where it usually is involving larger blood vessels of the brain, and it's associated with obvious acute symptoms. So difficulties with speech, facial drooping, weakness of one side of the body. These are basically one of the most recognized neurological complications of sickle cell disease. But thankfully, recent research has actually decreased the risk of overt stroke in this population. So transcranial Dopplers are now used to look at the blood flow, the blood velocity in these larger vessels, and to predict who is at highest risk for overt stroke. And those patients with those higher velocities are put on transfusion therapy, which decreases the velocities and decreases their risk for stroke. So now overt stroke in sickle cell disease is much less common than it used to be previously. What is more common now is silent cerebral infarction or silent stroke. And this is typically involving the smaller blood vessels of the brain, and it doesn't present with any of those acute symptoms that we see with overt stroke, which is why it's termed silent stroke, but it is not completely silent. In fact, it can have associated symptoms based on where it is in the brain and how large it is in the brain. Silent cerebral infarctions are also important because once you have one, that puts you at increased risk for having more, and it puts you at increased risk for having an overt stroke. So they're not entirely without additional sequelae. And then silent cerebral infarctions cannot be predicted by transcranial Dopplers. And also, you can treat them with transfusion therapy, but the research on that is not very strong, right? Where if you put someone who's already had a silent cerebral infarct on transfusion therapy, you can prevent them from having either another silent cerebral infarct or an overt stroke. But again, it's not strong research, and transfusions are not without their own side effects and complications. And so it's been difficult to use that in clinical practice. And then at the bottom of the graph is what I see most commonly in my clinic for children with sickle cell disease and neurodevelopmental disorders, and that's children with school problems and cognitive dysfunction. We think this is due to suboptimal oxygen delivery, related in part to anemia that these children experience. But also there are some other factors at play that we think are affecting this, things like inflammation and other things that have not been completely explored quite yet. And so this is a graph from a natural history study of sickle cell disease. And you can see here that these patients are at risk for different types of stroke over the lifespan. So they have both hemorrhagic stroke as well as infarctive stroke. And the infarctive stroke graph also includes the data that I was talking about from the silent cerebral infarctions or the silent strokes. And so you can see that the highest risk for those infarctive strokes is actually in children under the age of 10. And I just want to briefly take a moment to emphasize the point that I'm making about silent cerebral infarcts being silent strokes. Silent cerebral infarcts is a term that a lot of hematologists and sometimes neurologists use with our patients with sickle cell disease. And I feel like it's a misnomer. These are lesions on the brain that have T2 hyperintensities, and they are in fact silent strokes. And that is per the American Society of Hematology guidelines, as well as the American Stroke Association guidelines as well. And so sometimes when we see these smaller lesions on MRI, we think, oh, these are clinically silent. Oh, these don't have clinical relevance. But in sickle cell disease, they do. And again, we already talked about how if you have one, that puts you at risk for having more, and it puts you at risk for having an overt stroke. And then in that they're not truly silent in some of these patients, that they can have localizable symptoms associated with the strokes. So there is research showing that these may be even more common than we originally thought in patients with sickle cell disease, the silent strokes. And some research that's questioning if they're even more common, are they really associated with cognitive dysfunction? And that research is ongoing, but there is a lot of past research that shows that there are sequelae. And so really using the term silent stroke, particularly for this population, when you're talking with patients, is really the right thing to do. So let's talk a little bit more about these silent strokes. So they're the most common neurological complication in sickle cell disease, probably similar to headache in this population. As you can see here, the risk for silent strokes changes over the lifespan. So in children around 5 years of age, about a quarter of them have already had at least one silent stroke if they have SS or S beta null type sickle cell disease. By 14 years of age, 1/3 of patients with those subtypes have had at least one silent stroke. And then in adults over the age of 30, 50% of those patients have had a silent stroke. And so again, it's highly prevalent and prominent in these patients. And then in terms of where these are occurring, so it's predominantly, this is actually a study looking at school-age children with sickle cell disease, almost 300 of them who've already had one silent cerebral infarct. And in this study, they noted that the silent cerebral infarcts were happening in the white matter of the brain predominantly, and were predominantly impacting the frontal lobe and the parietal lobe. And again, because we know that these predominantly affect those locations, the symptoms that we're looking for are symptoms associated with frontal lobe and parietal lobe dysfunction or damage. And why do they localize to those areas? Well, it's related to cerebral physiology. And so this is the top row of these images is a heat map looking at the locations of the silent cerebral infarcts from that study that I just referenced. And then below it is basically showing the areas of lower cerebral blood flow in the brain in red. The areas in blue are that same density map, the same regions shown in the heat map. And then in purple are the areas of overlap. So these areas of the brain that are being hit by these silent cerebral infarcts are these areas associated with lower cerebral blood flow, kind of these watershed areas of the brain where there may not be enough blood supply to be sustained well when there are hits, when things like infection or acute anemia or dehydration are occurring. That's when these can happen. And there's been some additional research, again, to support this. You can see here that looking at cerebral blood flow over time, that there is a lot of oxygen, there's increased oxygen extraction going on as the cerebral blood flow increases. That oxygen extraction actually reaches a critical mass, and that leads to increased infarcts in these patients. And then it's also important to think about other things that influence cognition, not just in sickle cell disease, but in the general population. So this, again, is data from that silent cerebral infarct multi-center clinical trial, where they looked at, they grouped patients according to their brain injury status, so if they had an infarct or did not, and also grouped them according to their parent education status. So you can see here at the top, the patients with the highest full-scale IQs had no prior history of infarct, and their parents had some college education or more. And then the patients with the lowest IQs had an infarct of some sort, and their parents had a high school education or less. What you also see on this graph is that the IQ points are going down over time, suggesting that sickle cell disease has progressive cognitive decline in certain patients. And so you can see that they lose about 10 IQ points over a span of 10 years. And again, that's regardless of brain injury and regardless of parent education status, which is a marker for socioeconomic status. And so that's the other thing that's at play here, the anemia, the inflammation, the as yet not completely measured factor that's going on in these patients and their brains. So just in case you were not aware, there's a lot of research out there looking at cognition in children with sickle cell disease. And I just want to bring your attention to a few review studies looking at different articles over the years. So a study by Allison King at WashU looked at 10 past studies looking at cognitive function in school-age children with sickle cell disease and silent cerebral infarct. The patients with sickle cell disease and SCI had lower full-scale IQs than children with sickle cell disease without silent infarcts, but both groups had IQs that were lower than the normal levels. Another systematic review looked at 19 studies and compared IQs across multiple groups. Highest IQs were in healthy or sibling control patients, followed by children with sickle cell disease without brain injury, followed by children with sickle cell disease and silent cerebral infarcts. And then with the lower IQs were children with sickle cell disease and stroke. So really, again, you see that brain injury impacts these patients, but also that there's something else going on in sickle cell disease that's impacting cognition. Another study looked at IQs and other cognitive domains across the lifespan, and really found that infant and preschool age children with sickle cell disease had deficits in full-scale IQ, executive function, and attention, again, consistent with the patterns of brain injury that we see, and that verbal reasoning in these younger patients was predominantly what you see being affected. And then in school-age children and adults with sickle cell disease, perceptual reasoning and especially processing speed were the things that were most affected in these patients. And then another study by the same group looked at correlates of hematological function and cognitive domains, and saw that hemoglobin was associated with full-scale IQ, language, verbal, and executive function cognitive domains. That transcranial Doppler velocities, again, that marker of stroke risk, so not actual stroke, but stroke risk, was also associated with visual, spatial, and perceptual reasoning. And then they also looked at socioeconomic status and noted that that impacted a lot of the cognitive domains as well. So again, there are multiple things at play here. And just to take a moment to focus on adults with sickle cell disease, this is one of the best studies that's been done looking at adult patients with sickle cell anemia. So they took patients with no prior neurological history, no history of stroke or other neurological issues. They had normal neurological exams, and they had normal MRIs. And they compared them to age and race-matched controls from the same zip codes, so from the same communities. And even in these neurologically intact adults with sickle cell anemia, they saw differences in performance IQ, perceptual organization, working memory, and especially processing speed. So again, even in the absence of obvious signs of brain injury, there is still something going on in these patients. And so, some of you may be wondering why you haven't heard about this, given, all of the data, all of the information that's out there. And there have been a few explanations over the years, over the decades, that have been given for poor intellectual and school performance in patients with sickle cell disease. It's been attributed to school absenteeism and chronic illness, socioeconomic status, psychological problems due to chronic illness, also use of pain medications in this population. But what has been overlooked in the past and is in the most recent decades starting to be focused on and noticed more is that these patients are actually suffering from ongoing neurological injury due to sickle cell disease. And that is predominantly what seems to be going on here, in addition to other factors. So some of those other factors are, again, making note of the fact that this disease affects people of color predominantly, not just in the United States, but across the world. And so this was a perspective in the New England Journal of Medicine in 2020, where they talked about racism and sickle cell disease. And I'll just read the quote from this. There may be no population of patients whose healthcare and outcomes are more affected by racism than those with sickle cell disease. Patients with sickle cell disease are too often marginalized and dismissed while seeking medical care when their bodies hurt and they cannot breathe. And I highly encourage you to read this perspective. It gives a number of recommendations for things to do and things to not do when helping these patients. It's a very interesting read. In addition to that, there is also data comparing sickle cell disease to other diseases and noticing the impact of these things. And one of the most common diseases it's compared to is cystic fibrosis, another rare genetic disease. And you can see here that sickle cell disease approximately affects 3 times the people that cystic fibrosis affects, and again, predominantly affects people of color. That they have somewhat similar lifespans, although sickle cell patients are surviving longer, and similar lifetime costs. But you can see that the NIH funding, while similar overall, the funding per person affected is significantly lower in sickle cell disease. Foundation funding is also significantly lower in sickle cell disease, and that's overall and per person affected. And what that can do, what money can do, is it can also determine interest. And so you can see here that there are fewer publications in sickle cell disease in comparison to cystic fibrosis. While they do have similar clinical trials and FDA drug approvals, you can see that over time, that money and that interest has led to a lot more drug approvals over the decades in cystic fibrosis than in sickle cell disease. However, hopefully you have all seen on the recent news that there has been approval for 2 gene therapies in sickle cell disease, which was released in December while we were all at the American Society of Hematology meeting. And so you can see here that there's been a lot of attention and a lot of press on this, that it truly has brought hope to a lot of people with the disease. But of course, there is a price tag to that hope, and it's fairly significant. One of the curative therapies is 2.2 million, the other one is 3.1 million. And so this is something that means that it's not really able to be rolled out to the public clinically quite so quickly. FDA has focused on this, and this is kind of their next thing to work with these companies on decreasing that price tag. There are certainly people looking at the costs of the disease over the lifespan versus the cost of this drug to justify prices to insurance companies. But again, at least there are new therapeutics that are out there for this disease. And so a couple of years ago, we did take a look at the different neurodevelopmental disorders that we were seeing in our sickle cell clinic at Kennedy Krieger. The most common diagnosis we were seeing was ADHD and developmental delay. That was followed by attention issues, which was actually subclinical ADHD. So patients reporting attention issues, but that didn't quite reach the threshold of ADHD. Then we saw patients with specific learning disabilities in math and reading. At the far end of this graph, you can see that at this point in time, we had not seen any patients with sickle cell disease and autism spectrum disorder, which was unexpected and surprising, actually, at this point in time, since there would not be a reason to not be seeing autism spectrum disorder in this population. So looking closer at this data, we began to wonder why children with sickle cell disease have ADHD. And are the ADHD features that we see in these children different from the ADHD features that we see in children in the general population? Should we be screening, evaluating, and treating these children with sickle cell disease and ADHD differently than other children? And that speaks to the predominance of frontal lobe injury in these patients, and if we should be doing neuroimaging, which is not something that we do routinely in ADHD in general. And then, do these children have an increased risk of developing neurological complications in the future? So just like silent cerebral infarcts lead to increased risk of future brain injury, is ADHD also a harbinger of things to come in terms of neurological complications? So I hope that through what we've talked about so far, that you have started to see sickle cell disease, as I do, as kind of a neurodevelopmental disorder. And that's because while it is a blood disorder, the central nervous system is very affected by sickle cell disease. Those effects can start early in life, can be associated with neurocognitive dysfunction. They can have localizable symptoms related to that brain injury. And also, there's also the social and environmental context with the disease process. And so really and truly, sickle cell disease has a lot of features in common with some of the disorders that we treat and that we study. And so it's something that's very important to know this background about. We did take a look at the entire population of sickle cell patients at the Hopkins Pediatric Hematology Clinic, and looked at the diagnoses of neurodevelopmental disorders in everyone in that clinic. Now, everyone had not been screened, so you cannot call this a prevalence study, but a co-occurrence of these disorders. And so you can see here that we predominantly saw language disorders and, again, ADHD in these patients, and that's the bar in black. The bars next to them in gray are the rates of these disorders in children in the US. In medium gray is Black children in the United States, which is actually most comparable to our population in Baltimore. And then the last one is Hispanic children in the United States. And you can see that in almost all of these disorders that the rates in the sickle cell patients is lower than the rates in Black children in the United States and in children in the United States. And that was unexpected. We were thinking that these patients would have much higher rates of these neurodevelopmental disorders because of not just the effects of sickle cell disease, but also because they can still, come through these disorders in more typical ways, similar to the typical population. So that led us to be concerned that we were missing patients with these diagnoses, with these disorders, possibly because we weren't properly screening them or that they weren't getting evaluated at all. And then again, you can still see on the far side of this graph that autism spectrum disorder, that we had seen a few patients with this disorder, but that it was still lower numbers than expected. And so we took a closer look at the patients with ADHD and the patients with language disorder, but I'll just talk about the ADHD data here. The majority of these patients were male, similar to the general population. The majority had sickle cell anemia, which again, it's the most common subtype, so that's not unexpected. A lot of these children were on disease-modifying therapy, hydroxyurea, leading us to think that they had higher disease severity than other patients. About just under half had seen a behavioral therapist, which is one of the gold standard treatments for ADHD, and 63% were on ADHD medication, which is the other gold standard treatment for ADHD. In addition, these patients did have a higher rates of having a stroke, and that was significant. That stroke history was significant. So we do, in our clinical practice, we do get MRIs on all patients with ADHD and sickle cell disease to screen for stroke. And so we wanted to study this further, and so we did start a prospective study called SCD ADHD, and we enrolled children between 8 and 12 years of age with and without ADHD and with and without sickle cell disease. And so we basically did MRI training in these patients, and were able to get MRI scans, did cognitive testing in these patients, and got blood draws. And we're just starting to look at that data, so I'll present some of that data to you. This is an example of one of the patients that inspired this study. I began seeing her at 5 years of age. Her mom had concerns about her that were consistent with ADHD. I had mentioned the concerns about stroke in patients with sickle cell disease and ADHD. And so the parent was very motivated to have the child get an MRI and did not want her to have sedation or anesthesia. Now we're talking about a 5-year-old with ADHD. So that can be very difficult to get a high quality MRI in that patient population. But her mom was relentless, had her watch YouTube videos, had her practice at home, and she was able to get a pretty good clinical MRI at 5 years of age, which is that larger image on the left side of your screen. Now, 3 years later, she turned 8, and we put her in the study. And so in the study, she had another MRI, and on that MRI, we did see these lesions. They did not quite meet size criteria for silent cerebral infarct, but we did note that they were present because silent cerebral infarcts, they can also progress and become larger over time. And our radiologist for the study was actually looking at these images and pulled up the old clinical MRI and said, you know what? I think that this was there before. And I think that we missed it because while it was a standard clinical MRI, it was thicker slices and lower resolution than your research MRIs. And so at least one thing that we're learning from this study is that we may need to be doing higher quality MRIs in patients that we suspect have a higher risk of brain injury and sickle cell disease. And the guidelines support that, suggesting that it be done with 3T MRIs if possible. But I would also suggest thinner cuts as well in order to pick up these lesions that have clinical significance. And then looking at some of our other preliminary data, and I'll go through this quickly. I'm looking at the time. So we did see, as expected, relationships between cerebral blood flow and hemoglobin in these patients, in both our sickle cell and control patients included in this smaller sample. So as hemoglobin increases, cerebral blood flow decreases. As the percentage of hemoglobin S increases, cerebral blood flow increases. So trying to get more blood flow to those areas that are not getting enough hemoglobin or enough oxygen. And then we also noted there are different models that you can use for the cerebral metabolism MRI studies. And so we used a model that was created that was a combination of two different models that were created. And we did note, again, that cerebral blood flow rates were higher in sickle cell patients than control patients, and that oxygen extraction fraction was lower in the sickle cell patients than the control patients. And we think that's because the blood flow is rushing through the vessels so quickly that it's the oxygen is not able to be extracted as efficiently or as well as in the control population. And so this is something that, again, is under further study. And then we also took a look at functional connectivity in these patients. And this was, again, just a preliminary look. We're looking more closely at this data now. We saw that patients with silent cerebral infarct had lower functional connectivity in the control network. We saw associations between hemoglobin and control, salience, ventral attention, and visual networks. And in the sickle cell participants only, we saw associations between the visual network and hemoglobin, and that association persisted even when we adjusted for age and sex, which you can see here. And then lastly, we took a look at our preliminary data with regards to diffusion tensor imaging, so looking at the white matter integrity and microstructure. We were able to use our control participants to create basically a confidence interval of normality. And then we put in the sickle cell data, and we noted that there were 4 participants whose DTI metrics, so FA and MD measures, were outside of that confidence interval, so were considered to be in the abnormal range. All of those patients had abnormal MRIs. 3 of them had silent cerebral infarcts, and 1 of them had a different abnormality on their MRI. And then 3 of those 4 patients also had abnormal full-scale IQs. So we just presented this data in December at the American Society of Hematology conference, and so we'll be looking to write this up and publish it soon. So then I just wanted to return to this natural history study, and again, noting that patients under 10 had the highest risks of stroke. So from our study looking at 8 to 12-year-olds, we definitely saw that that was true, but that a lot of patients already had brain injury or neurocognitive deficits at that point in time. And so we knew that we needed to look at younger patients. So when you look closer at the data from that natural history study, the highest risk is actually in patients between 2 to 5 years of age. Those are the patients who are having strokes. And it can be obviously difficult to diagnose stroke in children, but it's incredibly difficult to diagnose stroke in children between 2 to 5 years of age. And as you can see, there has been a publication looking at this and noting that these children under 5 are having neurological complications, that it's difficult to diagnose in these children, and that we're seeing silent cerebral infarcts and cognitive impairment most commonly, but it's very difficult to detect that as well as overt stroke. And so we have our most recent study is actually called SCD Baby, where we are looking at children under 6 years of age with sickle cell disease. You can see here we're up to about 25 participants in the study, ranging in age from 9 months to 56 months of age. A little bit over half of them are male. We are always trying to include all of the different sickle cell subtypes in our studies just for generalizability, but we still have predominantly patients with SS disease. These patients have cognitive scores in the normal range, and we are doing different tests depending on their age. So starting off with the Bailey and then looking at the WIPSI. And then a majority of these patients are on hydroxyurea as recommended for young children with sickle cell disease to be started on hydroxyurea as soon as possible. And so what we are doing in these patients is we're actually doing that same MRI training that was inspired by my earlier patient. So our behavioral therapists are working with these patients, starting with an evaluation at age 3 when they come in for their study visit, and then seeing what they need to work on, giving the parents homework, so that they can work with them and train them at home, and then bring them in to, again, do formal training on our mock MRI scanner, which is just a decommissioned MRI that we use for training. On that MRI, we're able to play the MRI sounds, and the children are actually able to watch a video while they sit in the scanner. And so they kind of treat it as a game. They call it a rocket ship. And they're able to watch a video when they come in for their research MRIs, for their official MRIs as well. We let them pick out the video they want to watch. And honestly, it's usually a long day and they've had a big lunch and they fall asleep in the scanner at some point, and we're able to get the scans with no problem most of the time. So we're up to about 17 patients who have gone through the MRI training. At this point, of those patients, only 2 were unable to complete their initial and exit study MRIs. One patient had severe behavioral issues, severe developmental delays, and was not able to do the training. The other patient had language delays and some behavioral issues, was able to complete the training and do the initial MRI, but basically refused to do the exit MRI a few years later. And so you can see here that most of the patients are able to complete the MRIs with training, just 1 or 2 times training. There's a patient on here with 7 trainings, and that was because they only could come on weekends. So I had to train them, and I am not a trainer. I'm not the person to do this. So it took quite a bit for me to figure out that this child really just wanted to pick a prize out of the vending machine, specifically gummy bears. And once we had that established, she went in the scanner, no problem. And we also had gummy bears on hand for her when she did her exit MRI, and she initially refused. They showed her the bag of the gummy bears, and she went right in and did her scan, no problem. So it just took me a little bit more time to figure her out. Now, the other thing to note about all of these studies is that there are a lot of them that are now shown in red that are abnormal. So this can be SCI, but it's also other things. But almost half of these patients had abnormal MRIs. And from that chart that I showed you, looking at the rates of silent stroke in just SS and S beta null thalassemia patients, 25% would be the expected rate for children approximately 5 years of age. But that rate is probably less because it's so difficult to not just detect silent cerebral infarcts in these patients, but also, they're asymptomatic, right? We're not seeing issues until they enter school and start having difficulties with attention and behavior. We can't always get clinical MRIs in these patients. And if we are getting clinical MRIs, it may not be the high quality MRIs that we need to diagnose and detect this. So I will skip over this case actually and go straight to the guidelines for the last part of this. So the current guidelines in sickle cell disease released in 2020 do ask that every patient with SS and S beta null thalassemia or sickle cell anemia get at least 1 MRI during their school age and 1 MRI as an adult. And that's because of the high rates of brain injury in this population. They basically are recommending, in terms of developmental screening, cognitive screening, that you do the standard recommendations that we recommend for all children, even though these patients are at high risk for cognitive and developmental disorders. And so it basically says that hematologists or clinicians looking at taking care of these patients do developmental surveillance by asking about developmental delays in preschool children and neurodevelopmental disorders or specific symptoms of ADHD in the school-age patients. And again, that's because of that frontal lobe predominance of brain injury. And then for children with abnormal surveillance, they suggest formal screening by a psychologist or a pediatrician that can then do the developmental or cognitive screening. And then if those patients have positive surveillance and screening, then they should see someone like me for a full developmental, cognitive, or medical evaluation to diagnose any related disorders and identify modifiable risk factors, and then receive appropriate treatment. And so we know that the primary care physicians are very busy, and that it can be difficult to do developmental surveillance at every visit. They are doing the standardized screening tests at 9 months, 18 months, and 30 months, and then paying special attention to patients at times of transition, so transition to elementary school, middle school, and high school. And the screening rates are improving over the years, but are still fairly low, and this is because of time limitations and inadequate payment. And it's always difficult to put guidelines into practice, even though these have been around for a few decades now. So we did take a look at how often patients with sickle cell disease, children with sickle cell disease that are young, were getting developmental screening as well as autism screening, both of which are recommended by the American Academy of Pediatrics. And we found that for the developmental screening, most of the patients were getting some sort of assessment, but that assessment was not occurring within 1 to 2 months of the recommended timeframes. And also those assessments weren't occurring using validated tools, screening tools that are recommended by the AAP at those times. It was really more of a developmental surveillance, looking at guidelines, checking in with the parent about any developmental concerns. So it's happening, but it may not be happening per the guidelines. Now, interestingly, when we looked at the autism screening, which is supposed to occur at 18 and 24 months, that was not happening in a majority of patients, actually. They were not being assessed with autism. However, when they were being assessed, it was being done with a validated tool. Most commonly, the MCHAT was being used. And that was well documented in the charts. And so it was kind of like an interesting, different look at these two types of screenings. And it also calls into question the information that I presented previously, where we were seeing lower rates than expected of autism spectrum disorder in our sickle cell population at Kennedy Krieger and Johns Hopkins. And that possibly is because they aren't being screened and identified. And so this is something that we are focusing on. And we did publish a case series looking at the patients that we had with sickle cell disease and autism spectrum disorder, and asked those parents why they thought that this was undiagnosed in their children. And they basically just said that they asked for but were not able to receive the help with diagnosis that they were looking for, and really wanted to stress that early detection was important and that we need to educate and inform them about these things, about these concerns and increased risk. So lastly, I just wanted to note some changes to our clinic that we noted during the pandemic. We had to switch to telehealth like everyone else in April of 2020. And we actually have had a pretty poor, more like 50%, honestly, show rate in our sickle cell neurodevelopmental clinic. We are not always a priority for these patients and families. A lot of times they're in the hospital. They almost always make their hematology visits. But they don't always come to see us. But once they meet us, we usually have a pretty good show rate. But we looked at the same 6-month period in 2019 as the first 6 months of the pandemic. And with telehealth, our show rate dramatically improved to 100% from 68%. And a lot of those patients had missed appointments in our multidisciplinary clinic. So it's the same patient population that just started showing up in telehealth. Now in Maryland, we have a lot of patients that live on the Eastern Shore, so pretty far away from Baltimore, and who drive in for those appointments. So we know that telehealth was easier for them in terms of transportation. A lot of them did do the visits on their phones or laptops. And a lot of the patients that showed up were the patients with IEPs, and so that we do a lot of work for. And then it was interesting to note that maternal education was also a predictor of show or no show status. And so we're working on publishing this data hopefully soon. But we are continuing to use telehealth in our clinic where we can for these patients, for this patient population in particular. And so just want to say that in closing, that we have the utmost gratitude and appreciation for our sickle cell patients and their families that really inspired the research that we're doing. We really don't do, we do a lot of research based on what they tell us about. And that is what makes it easier for us to recruit these patients, I would say. In addition, we have a whole multidisciplinary team of people without which this work would not be possible, especially our MRI techs and MRI trainers. There's just no way that we could do this without them. And we really do see patients across the DMV area and are grateful to have quite a bit of funding. And our team has grown over the years, starting with just the 4 of us, and then expanding now to have a team of people. So we have myself, neurodevelopmental disabilities trained, a neuropsychologist, a behavioral therapist, an education specialist, a child psychiatrist, nursing support, administrative support, and now an adult neurodevelopmental disabilities trained physician as well. So we now see children and adults with sickle cell disease. So I think that is it for me. And thank you so much for your time and attention. And I would love to take any questions. I will stop sharing.
Thank you so much. That was an amazing presentation. I think we had one question so far that came in the chat.
Yes. Oh, I can see it. All right. So our neurological exam does not readily identify cognitive disorders. Adult neurologists seeing dementia may use a MoCA or similar. What would you recommend we consider as an adjunct to our exam to screen for ADHD in clinic for this population? So great question. So in the pediatric population, if you want to screen for ADHD or other related disorders, I think the Vanderbilt is probably the easiest thing to access. It's easily available on Google, online, it's free, and you can see both the forms for parents and teachers as well as the scoring forms online. So it's just the easiest one to do. My neuropsychologist primarily uses the DuPaul because that corresponds a little bit more to the DSM criteria for ADHD. But I use the Vanderbilt, again, just because it's so easy to get to hand to patients on the way out the door and have them mail it back. In adult patients, the MoCA is what the Hopkins Adult Sickle Cell Center uses. However, we haven't validated the MoCA in adult patients with sickle cell disease, so we don't know what cutoffs to use. So typically we're using the standard cutoff for MoCA that's used in the general population, but of course that's created for patients with dementia. At the same time, you could use this to kind of longitudinally track patients' cognition over time. And obviously, if you see someone with a score below the normal cutoff for dementia, you're going to refer them. We are working on a study where we are working on validating the MoCA or the RUDOS, another similar cognitive screening test in adults with sickle cell disease with standard neuropsych testing. So we're working on that now. Hopefully we'll have those results for you soon.
Yes, Brian and Ziska, adult neurology. I grew up and went to medical school in South Africa and did my internship. I never saw a patient with sickle cell disease or heard of one working at University of Cape Town. And looking at your initial map of Africa, there was very little sickle cell disease actually described in Southern Africa as opposed to the rest of Sub-Saharan Africa. Now, the Bantu-speaking people who predominate in parts of Central and certainly Southern Africa probably started immigrating. There used to be an argument as to whether they arose separately or not, but they're now classified as members of the Congo of Benue people of Eastern Nigeria. There's similar languages. It's not totally based on languages. And this large immigration, beginning really in Eastern Nigeria, I don't know, 2,000 years ago, gradually moved to Central and then Southern Africa. As I said, certainly sickle cell disease, which everybody learned at medical school was not seen to speak of in South Africa. Since 1994, since apartheid ended, there's been quite a bit of immigration even from Central Africa to South Africa. And I don't know if a study is being done of the immigrants from Central Africa, from even as high as Tanzania, Kenya, etc., as well as the Congo. I noticed that sickle cell disease also exists significantly in parts of India. And I wonder if, it's not going to make any difference to the treatment at the moment, but were these different mutations that occurred in, let's say, in West Africa and India, or were there immigrant populations from Africa who we know there was considerable interaction between East Africa and India historically? And I just wonder if it was one source or multiple sources, and why the Bantu-speaking people of South Africa, who at least 70% of the population when I was there, had almost no or such low incidence of sickle cell disease, which was demonstrated by your map of Africa.
Yes, so it's a great question, and unfortunately, I am not certain that I can answer it given my neuro background, but I can say there are different haplotypes of sickle cell disease that are named for the different regions that they are thought to have originated from that do predominate in certain areas. And so these haplotypes, I think, are different in the different regions. I can share that map again very quickly, just showing what you're talking about in terms of where this is happening. So again, as far as I know, the haplotypes do not necessarily correspond to clinical symptoms, which I think that's been shown in some research. There's other research showing that maybe specific things are, but this is something that's being looked at different centers in the continent of Africa. I think predominantly in Nigeria, although I know that there are some other countries that have sickle cell research centers going on. There is quite a bit of research coming out of India as well, looking at sickle cell disease there. I am just not as familiar with that research. A lot of the more recent studies coming out of Nigeria have looked at the brain in these patients because there are so many patients. And they have a lot of really good data with large sample sizes that we haven't been able to get in other countries. That is really starting to change the landscape of treatment. So high quality research that is informing clinical care. Let me stop sharing again.
May I?
Yes, please go ahead, Dr. Giri.
Thank you for such an enlightening and erudite presentation. Really enjoyed it. And again, one of the big, areas that you touched on, which has not been, appreciated, is that SIT trial brought out about the silent influx. And again, using the word silent, like you pointed out, is a disservice because it is silent to our examination, but these are causing ongoing difficulties. And one of the things is, how do we pick them up if we can't pick them up clinically, is by imaging. And I was hoping that you would say that once you identify these children, that you're starting the imaging at an early age, maybe under 1, and being progressive, that you would do it periodically. Is that anything that you would be planning on? And also, what do you think is the future of treatment of sickle cell now that we have definitive gene therapies and so on?
Yeah, great questions. So starting with imaging in these patients. So I would say we do not do imaging in patients routinely under the age of 5 or before they can do it without sedation or anesthesia. That is because these patients are high risk for complications with sedation and anesthesia. And the NIH actually isn't allowing people to do research in these patients getting MRIs using sedation or anesthesia because of the death of a research participant in a baby sickle cell disease study. So in a very young child with sickle cell disease who had complications from anesthesia and died during a research study. So that is why our research is looking at how young we can do MRIs in these patients using the behavioral training. Our youngest patient was, I think, 3 years and 10 or 11 months of age. And we was able to successfully complete the MRI and actually had the highest quality MRI of all of the patients in our study, as commented on subjectively by our radiologist, but also using our quality measures, which we're hoping to publish soon. So we would suggest basically getting it in the patients as soon as they're able to do it without sedation and anesthesia to get a first MRI. If the patient has significant delays, cognitive delays, developmental delays, then we would likely have them go ahead and get the MRI with sedation and anesthesia, because then we're extremely worried about brain injury, and it would change treatment if they had a stroke or even a silent stroke. If they have the cognitive sequelae already, we want to do whatever we can to preserve brain function. I would say once we see a patient with a silent infarct, we do repeat their MRIs. We do repeat their MRIs every 1 or 2 years. And that is in order to see if that infarct has progressed or if there are new ones. Again, once they've had one, that puts them at increased risk for having more. And again, in patients with developmental or cognitive concerns, I would highly recommend getting those higher quality MRIs. I think you probably have like a stroke protocol that you may use for MRIs in patients that you're concerned about stroke. And I would suggest having something like that that you use for these patients, something where you get the diffusion, where you get the, the thinner cuts, where you get higher quality MRIs on a higher higher strength magnet scanner whenever possible. I think your second question was about the future of treatment in sickle cell disease based on what we have. I mean, based on the global studies of sickle cell disease, it is showing that basically these deficits, these complications are, we can stop these things with treatment, whether we are treating the anemia, whether we are giving them hydroxyurea to decrease the complications and prevent hospitalizations, and whether they are getting transplants and even gene therapy. Those can really get rid of these symptoms and get rid of the sequelae. It remains to be seen what the long-term effects of these things are. There's a lot more data in transplant, but not everyone can undergo transplant or find a match, right? So I do think that eventually my hope is that we can eradicate this disease and I can be out of a job, because that would be the ideal thing. However, resources-wise, I don't see when gene therapy is going to make its way to be used globally. And so it's important to figure out what works, because we do have a lot of other new treatments that are FDA approved for sickle cell that have flooded the market. So it's important to figure out what works, what is neuroprotective, because that's a key outcome for these patients. But again, what also increases their quality of life, what gets rid of the pain, what gets rid of the need for hospitalizations. And so I think that as we try these new therapies, there will be more and more studies looking at these additional complications impacting quality of life. And we will hopefully be able to significantly improve that while we improve the availability of the curative therapies for everyone.
Thank you.
Yeah.
Thank you so much for your presentation. In the interest of time, because I know a lot of people do have to get back to what they're doing. If anyone has any more questions, if I will share your Kennedy Krieger email with the group, and then they can feel free to ask you.
Great. Thank you.
All right, everyone, please have a good Friday. Okay. So, and now meeting.